Well, thank you everybody for joining us for today's session. Today we have joining us Dr. David Putrino. He's the Director of Rehabilitation Innovation at Mount Sinai Health System and Professor of Rehabilitation and Human Performance at Icahn School of Medicine at Mount Sinai. Thank you so much for joining us today. Just so everybody's aware, due to unforeseen circumstances, we're not going to be providing a CME for today's session, but we will be recording it and it will be available up on our iEcho website for anybody who wants to watch it later. And I'll go ahead and hand it over to you, Doctor.
No worries. Thank you so much. It's great to be here. And I know that we're, um, thinking a lot about um, vascular issues in long COVID and issues of coagulation and how that kind of relates to long COVID and long COVID symptoms. And today I'm going to talk a little bit about that, but I'm also going to talk about some of the other drivers of long COVID symptoms, how some of these drivers can be interrelated, and sometimes it can be a little bit tricky to understand the causality of those drivers. And then some of the potential treatments. We're going to talk through some of the potential treatments that are, out there and being trialed. Some of the potential treatments that already have a little bit of publication behind them, and uh, finishing off, I just wanted to talk about one recent clinical trial that we have recently completed that had some favorable results that I wanted to share. Um, so when we put together a document to kind of describe how we approach long COVID in our clinic, we really identified 10 key drivers of symptoms in people with long COVID. So rather than thinking about how to treat symptoms, a lot of people would say to me, well, how do you treat fatigue in long COVID? And it struck me as a bit of a confusing question because I think that first we need to understand what is happening to the person in front of us that is making them fatigued. There's a lot of different ways that long COVID can cause fatigue in a patient. And so the first thing that we want to do is try and understand what's driving the fatigue. What is the thing that is behind the symptom? And our constant teaching to anyone who will listen is treat drivers, not symptoms. So when you're thinking about long COVID, when you're thinking about what your patients are going through, try to think in terms of, okay, well, I understand that you're telling me that you're fatigued. I understand that you're telling me that you have migraines, that you have POTS, etc. But what could be behind that? So today we're going to talk about some of these common drivers. And the other point that I want to bring up about drivers of long COVID symptoms is that long COVID, the complexity of long COVID uh, often has to do with how dynamic symptoms can be, and and the acknowledgement that you may have one driver that is modulating. So, for instance, you may have a viral reservoir of SARS-CoV-2 in an immune privileged site. But that viral reservoir's activity may be waxing and waning based on immune regulation or based on the reactivation or inactivation of other viruses in the system. And that downstream can affect a lot of the sort of other drivers that we're seeing, like again, vascular dysfunction, autoimmunity, et cetera, et cetera. So, um, in addition to acknowledging that we have many drivers of symptoms, we also have to acknowledge that those drivers can change over time, and that can also affect the symptoms that emerge or how symptoms modulate over time. So, to dig into a few of these drivers, let's start with, what this education series is about, which is, vascular issues, coagulation dysfunction, which is something that we have seen to be an issue in people who are experiencing long COVID symptoms. We published this review in 2023, which aggregated a lot of the evidence um, around long COVID studies that had shown not just that people with long COVID are more likely to form these sort of fibrin amyloid microclots, but this whole cascade of SARS-CoV-2 antigen in the bloodstream causing platelet activation, endothelial damage and dysfunction, cytokine release, that then leads into this this situation where fibrin deposition is occurring in the bloodstream, red blood cells are getting sort of tacked together, and you start to form these microclots that can clog small vessels, that can affect blood flow, et cetera, et cetera. So from an early point, thanks largely to some of the pioneering work that was done by researchers like Doug Curl and Riccia Pretorius, we've seen that long COVID does have vascular and coagulopathy-like effects. Doug and Riccia's work has also spawned a number of publications really showing us that when we look at platelet poor plasma in healthy controls versus people with long COVID, we are much more likely to find these fibrin amyloid microclots in their system. So, these images were taken with fluorescence microscopy and platelet poor plasma that had been stained with THT, which turns amyloid proteins fluorescent green. And as you can see, and this is a finding that has been now replicated in many papers, in platelet poor plasma of healthy controls, you may see some microclots floating about, but in folks with long COVID, you really see large microclots and much more frequent presentation of microclots in the microscopy. So this idea that not only are we causing endothelial damage, we're also causing microclots. There's also been some findings, and this is a figure taken from a paper that was just published in 2026, but I think reinforced by a Nature paper that actually just came out, this week, showing that SARS-CoV-2 infection can reactivate all sorts of other viral infections, which we're now starting to see can have a profound effect on the endothelium and the ability of the endothelium to renew itself and regenerate itself through sort of sloughing of dead cells and regrowth of new cells. So you end up with this unhappy cycle in long COVID of reactivated pathogens that are reactivated by SARS-CoV-2, or even persistent antigen, SARS-CoV-2 antigen, circulating the bloodstream, causing immune dysregulation, immune exhaustion, senescence of the endothelial cells, and then impaired clearance of the endothelial cells, which then leads to microclotting, endothelial damage, endothelial scarring, and all sorts of vascular issues. So I hope that you can see here that, yes, vascular issues may be a really legitimate driver of long COVID symptoms, but it's also important to acknowledge that the driver behind the driver, some of the things that are pushing this endothelial dysfunction can be due to chronic inflammation, can be due to viral persistence, can be due to reactivated pathogens and herpes viruses. In terms of therapeutic targets, we have publications emerging showing that statins can have a good effect on this. CCR5 inhibitors like Maraviroc can have a good effect on treating some of this dysregulation, and straight anticoagulation. So, a couple of publications that have emerged in the last few years. Bruce Patterson's work showing that Maraviroc paired with a statin is a valid therapeutic option that has helped, a proportion of people with long COVID. We published a case report showing that use of single anticoagulation with a drug like enoxaparin can produce significant improvements in people with long COVID. And Riccia Pretorius and team have also published a really nice paper showing a case series showing that treatment of long COVID with triple anticoagulation therapy. So dual antiplatelet therapy paired with anticoagulation therapy had a positive response, a positive effect on a majority of people's long COVID symptoms. So although these are at this stage only case reports and case series, what we next need, is controlled randomized trials that will help us to better understand who benefits from therapies like this. What is the physiological or pathophysiological profile of patients who benefit from interventions of this nature? Moving into hormonal dysregulation. We do frequently see evidence of hormonal dysregulation in people with long COVID. We published early in 2023 evidence that HPA axis hormonal dysregulation was quite common in people with long COVID when compared to healthy controls. Namely, we were seeing reductions in morning cortisol alongside normal ACTH levels, where we would have actually expected changes in ACTH levels that were congruent with the changes in cortisol, morning cortisol that we were seeing, but we didn't see that at all, indicating that it wasn't just a reduction in morning cortisol that we were seeing in many of these long COVID patients. It was also dysregulation of the entire HPA axis that is potentially causing issues. In addition to HPA axis dysregulation, we also noted sex differences in symptom presentation. So women were experiencing certain symptoms more frequently than men, and men were experiencing certain symptoms more frequently than women. And interestingly, when we dug into those changes, we saw that these sex differences were actually associated with changes in sex hormones. So women who had low testosterone levels were more likely to have quite severe female predominant symptom presentations, and men who had low levels of estradiol were much more likely to have more severe male predominant symptoms. So this indication that some of these symptoms may be driven by hormonal dysregulation, both sex hormone dysregulation as well as HPA axis hormone dysregulation. In terms of therapeutic targets here, there haven't been no good studies to date on hormone replacement therapies and some of the other supportive therapies around HRT, but we certainly have seen anecdotally in our clinic good effects with sending people with clear hormonal dysregulation to an endocrinologist to receive hormonal replacement therapies or other supportive care to try to balance out some of these hormonal differences that we're noting. Then moving into immune dysfunction and autoimmunity. Again, to sort of harken back to our 2023 paper where we saw HPA axis dysregulation as well as uh, immune dysregulation, we noted that people with long COVID certainly had altered B cell behavior. So B cells were not behaving in the way that we were expecting. That indicated to us something that was quite interesting and indicating that we were seeing an immune system that was exhausted, an immune system that was producing a lot of antibodies for a lot of different things, but was not producing effective antibodies um, against pathogens and against other sort of um, uh, regulatory, immunoregulatory processes. So we saw this pattern that indicated T cell exhaustion and immune dysregulation in that direction, more inflammation but less effective, less a lower quality antibody production. Um, and and so along with this pattern of T cell exhaustion and altered B cell and T cell activity. Once again, similar to many other studies, again, including most recently the study that was published in Nature just this week showing herpes virus reactivations in long COVID patients. We also saw reactivation of pathogens such as EBV, CMV, HHV6 in these long COVID patients. As we think about how we might balance some of these patterns of T cell exhaustion and ineffective antibody production, even if you're seeing prodigious amounts of antibodies, and certainly you do see this in long COVID patients. If you test for IgG, for EBV and CMV, often in these long COVID patients, more often than not, you'll see outsized numbers, like very, very, very high beyond the outer range of normal, upper range of normal for EBV IgG antibodies or CMV IgG antibodies. So our question becomes, how do we work to regulate this system that is producing all sorts of antibodies that are ineffective alongside T cell exhaustion, so the T cells themselves not being so effective. And that's where we've targeted low dose rapamycin, where about 50% of the way through recruiting for this clinical trial right now, where it's a placebo-controlled RCT where we will be dosing folks with low dose rapamycin, which we use an escalating dose of 1 milligram a week to 2 milligrams a week to finally a stable dose of 4 milligrams a week, which we hold over a period of 2 months. And we will be looking at inflammatory markers alongside uh, markers of T cell exhaustion to really dig into whether or not low dose rapamycin is assisting in improving long COVID symptoms by regulating the immune system. Um, I think it's also important to note that alongside this sort of um, immune dysregulation, we're also seeing that long COVID patients uh, are creating a lot of antibodies um, for SARS-CoV-2 um, antigen, so spike protein specifically. So this is again something that we published in 2023, but actually more recently, when we were sort of looking into the why are we producing so many antibodies for spike? We actually went ahead and took some gut tissue um, from a whole bunch of people with long COVID and a whole bunch of people with healthy controls. Now, I know that these volcano plots are busy, but really what we're trying to show here is that in our samples, so we took gut tissue, and in addition to searching for spike protein in that gut tissue, What we also did was if we found spike tissue or if we found spike protein or if we didn't find spike protein, what we actually did was we looked at the tissue around it and we ran proteomics to try and understand, is the tissue reacting to the presence or absence of spike protein? And what was very interesting was in people with long COVID, we saw very clearly that their tissue was reacting very strongly to spike protein embedded in their gut. But when we also found areas, ROIs, regions of interest in people with long COVID that didn't have spike protein, their gut was actually it was the proteomic or the proteome of the gut tissue around that area was actually not bad at all. It was not releasing proteins that were problematic in any way. Now, when we looked at uh, people with long COVID versus healthy controls, where we also found spike. So in some of our healthy controls, we also found spike. What we saw in the healthy controls is their gut proteome was not reacting to the spike protein at all. So for whatever reason, our healthy controls were able to tolerate spike protein hanging out in their gut versus our people with long COVID who had that same spike protein hanging out in their gut were producing all sorts of pro-inflammatory and pro-oncogenic proteins that we believe is driving a sort of chronic inflammatory issue, not just in their gut tissue. That's where we found the spike protein in this particular assay, because that's where we were looking, but all over their body, wherever the spike protein may be embedded or hiding out. So this slide, as busy as it is just telling us that there is something going on in the bodies of long COVID people that make their bodies react to persistent antigen that is being found in tissue, whereas healthy controls can still have persistent antigen. They have it less frequently, but they still have it sometimes, but their body doesn't respond to it. In terms of therapeutic targets for persistent antigen, I think that we are really all in on monoclonal antibodies that can cycle through the body, bind with persistent antigen that is sort of circulating wherever they find it, and then be excreted from the body as an immune complex. Our team is about to initiate a clinical trial with a new class of monoclonal antibody called VYD2311 to really test this theory out, where we will only be recruiting people with a past history of testing positive for spike protein, and we'll really be looking at what happens to their physiology throughout the infusion of monoclonal antibodies. Finally, on the immune dysregulation front, I just want to talk about some work that we did with Akiko Iwasaki's team. Oh, this is out of date. It is now published in Cell. And in this study, what we did was we showed that when we take purified IgG from people with long COVID, and in this case, in a dish, we exposed it to human neural tissue. What we saw was that human neural tissue would react with a lot of sort of inflammatory processes when it was exposed to long COVID purified IgG compared to the IgG of convalescent controls or healthy controls. We then went from exposing human neural tissue in a dish to IgG from our various experimental groups to injecting mice with this IgG, this purified IgG, so a passive transfer experiment. And what we saw was quite striking. So yes, some of the mice started to perform worse in balance and coordination if they received IgG from long COVID patients compared to if they received IgG from healthy controls or convalescent controls. But also we noted reduced grip strength, so weakness in the animals. But most strikingly, we noticed that animals that were injected with long COVID IgG were much more likely to experience increased thermal sensitivity, which we use as a proxy in animal models to pain. And what was particularly interesting about this finding was the fact that in almost all cases where the animals demonstrated increased sensitivity to pain, these were animals that received IgG from people with long COVID who had new onset pain as a symptom of their long COVID. So long COVID patients with pain whose IgG was transferred to animals produced pain-like symptoms in the animals. That was a pretty wild finding, and it led us to the idea that autoantibodies could be driving symptoms in a subset of people with long COVID. And therefore, we think about therapeutic targets like IVIG, of course, subcutaneous IG if IVIG can't be targeted, FcRn inhibitors, and other immunotherapies that could have a role at quite preferentially knocking out functional autoantibody production in people with long COVID without causing immunosuppression. I also want to point out that, we need to be picking our participants very carefully. FcRn inhibitors have already failed in a long COVID cohort in clinical trial because they took everyone. They said anybody who has long COVID and dysautonomia, we're going to give an FcRn inhibitor and we're going to see how you do. And that did not go so well. We really need to, and my hunch would be identifying individuals who have long COVID and new onset pain based on our experimental data. That would be a much more at this point, given the available literature that we have and knowledge that we have, that would be a much more sensible starting point for a clinical trial of FcRn inhibitors.
Oh, could I ask you? So you asked about pain. What do you mean by pain? A lot of our clients in our long COVID do have musculoskeletal pain, but what specifically makes them, is it so it is the temperature hot?
So no, so in this case, what was interesting was we actually tried to differentiate the pain subtypes. So in this experiment, we asked patients if pain was a part of their symptoms, since their long COVID diagnosis. So it's really, did you have pain before? No. Do you now have pain? Yes. And then we actually did the SLANS questionnaire to differentiate between neuropathic and more just typical nociceptive pain. And interestingly, in both cases, so regardless of what the SLANS predicted, it really was just anyone who had a new onset report of pain, their IgG produced symptoms in the animals.
Would it be more suggestive of small fiber neuropathy, are you saying, or not necessarily, or?
Well, it's an interesting question. And my question to that question, if you think about what David Systrom is sort of publishing around small fiber neuropathy, he thinks it's a function of inflammation as well.
Mm.
And so then it comes down to what's driving the inflammation. Is it functional autoantibodies or is it inflammation of some other source? And in this particular experiment, what we showed was the folks that were providing the IgG that was causing symptoms in the animals, when we looked at their HUPROT scores for autoantibody production, they were producing more autoantibodies than their peers. What was also interesting was it wasn't in any discernible pattern. So it was a bit of a chaotic presentation of functional autoantibodies. It didn't follow a pattern like other autoimmune diseases would, like, like Sjogren's or Hashimoto's. It was just more autoantibodies across the board, generally speaking. And then final driver I'm going to talk about before we finish up and go into some questions is just thinking about neuroinflammation and cognitive dysfunction, because I think that this is something that is, at least to our patients, represents some of the more disabling, but also certainly the most frightening symptoms when cognition is being affected. In 2022, we published some work showing that we published some cross-species work showing that even mild acute COVID infections could lead to white matter damage via neuroinflammation. And in fact, what we showed in the animal model was that specific chemokines were being produced that tended to cause microglial reactivity and white matter damage in animals that were infected with SARS-CoV-2 and went on to develop chronic behavioral problems after their COVID infection, as well as our human cohort of patients with cognitive decline had similar chemokine presentations in their blood work. After we published this work, Mike Van Alzecker's team at Harvard also did some really interesting work with PET imaging, where they used a radio tracer that picks up microglial activation, and they showed that in folks with long COVID, there was a lot more evidence, radiologic evidence of microglial activation compared with healthy controls who did not experience cognitive symptoms or cognitive impairment at all, really pointing us toward this idea that neuroinflammation is a legitimate driver of COVID-triggered or COVID-related cognitive impairment. And it's a huge problem. We published this work in 2022, just looking at the neurological quality of life in our long COVID patients just coming through the clinic. And what was fascinating was that, just over 60% of our patients reported at least mild cognitive impairment since their long COVID diagnosis. So this is cognitive impairment that is really interfering with activities of daily living and ability to function in society. And so, to finish off, instead of all the doom and gloom I've been doing up until now, I just wanted to share, a clinical trial that we just completed with an entirely novel technology to try and address some of this neuroinflammation. We were made aware of a technology called microtesla magnetic therapy. This is a therapeutic technique that uses low frequency magnetic fields that can stimulate both superficial and deep brain structures. And it reduces neuroinflammation by triggering something called mitohormesis. So it stresses mitochondria in the brain just enough that they start to trigger aggressive antioxidant and anti-inflammatory processes in the brain that theoretically are causing sort of drainage of neuroinflammation in the system. The device and the technology caught our eye because it had some pretty impressive work, both in a dish, in vitro, showing us that applying MMT fields to brain cells in a dish could significantly reduce inflammatory cytokine presentation. And then they went on to complete and replicate these findings in an animal model of neuroinflammation, showing that MMT being applied to animals with neuroinflammation, again, not only significantly reduced inflammation, but also seemed to improve some of the scarring that was being seen in these animals that were experiencing neuroinflammation. So we attempted a clinical trial. The device, as you can see, is pretty small and portable. Basically, it's a pretty easy protocol, pretty low intensity for our patients. They just need to put this headset on for 15 minutes every 48 hours. So the time commitment is minimal. The form factor is portable. And the clinical trial can be done mostly remotely. They don't need to come to a location-based area to get a treatment, which makes the trial low effort on the patient's part, which is good for folks who have post-exertional symptoms. We had a fairly simple protocol, but it was triple blind and placebo controlled. We took some baseline outcome measures. We took some outcome measures at the end of intervention, and we then did a follow-up at 8 weeks, so 4 weeks after the intervention was ceased, to retake all of the data at that point. We recruited 30 participants in this trial, 2-to-1 active sham randomization. We only accepted folks who had at least mild cognitive impairment, so they had to test one standard deviation below normative range in objective assessments being conducted by a trained neuropsychologist. They weren't allowed to have any other diagnoses that might affect cognition, so pre-existing diagnoses like a traumatic brain injury or something of that nature. And our primary outcomes for this study were just safety and feasibility of the device. Did we see any adverse events? Did patients willingly and easily complete the treatments? So to talk about the primary outcome measures, we saw no device-related adverse events at all. So that was encouraging. All of our participants finished the trial with 100% adherence, also encouraging. And importantly, our blind remained intact. So in the active treatment group, just under 60% of people guessed correctly. So 58%, so roughly 50-50. And in our sham condition, 40% of people guessed correctly as to which group they were in. So that really places us at a point where we are convinced that the sham was intact and people didn't really know if they were in the sham group or the treatment group. What was interesting that in addition to having no adverse events and seeing good adherence to the treatment, we also saw that in the MMT group, we saw some improvements in the cognitive tasks that we were measuring. So Trails A, visual attention improved, processing speed improved, attention and inhibition control, executive function improved. Emotional well-being increased quite significantly with a sustained improvement at 8 weeks. And in general, many of the participants were just telling us that this seemed to really move the needle for them. So we are, in addition to having this work under review right now, we also have, we will be releasing a preprint in the next week or so, where we're actually looking at the proteomics of the responders versus the sham group, where we're able to show that there does appear to be a proteomic signature of response to this particular type of therapy. So not everybody responds, but there is a subset of people who respond quite well. And lo and behold, they have a proteomic signature that actually seems to somewhat predict a favorable response to MMT therapy. Indicating once again, there is no silver bullet that treats all of long COVID, but we need to think about the drivers. We need to think about what's happening from a physiological perspective, and we need to match the right interventions to the right patients as we go. And we will be hopefully initiating a much larger multi-site randomized controlled trial of this technology in the coming months because the pilot went so well. It's definitely time to move into a larger pivotal clinical trial for the technology. So with that, I just want to share that we have produced a guide to clinical care of infection-associated chronic conditions and illnesses, namely long COVID, hypermobility spectrum disorders, ME/CFS, and chronic tick and vector-borne illness. It's a free download if you scan this QR code. I'm really grateful for a wonderful team that I have that has helped to produce this content, as well as all the wonderful people who help us every single day, our patients, our funders, just making these acknowledgements. And then thank you all for showing up, and happy to take some questions.
So thank you so much for that. That's a lot of information for us. And thank you for the last guide. I think many of the providers will often ask about what are the next steps as we're into our fifth year post the SARS-CoV epidemic. And a lot of our clients have been struggling still. And I guess your talk gives us some hope into hopefully making them at least hopefully getting a little bit better, or at least plateauing and not getting worse. In your clinics, do you see many of our clients are kind of plateaued? They aren't getting worse, but they aren't getting better. Have you seen some of these improvements kind of cross over to getting people who have had serious long COVID to becoming more functional?
Yeah, I mean, I would say we with every new therapy that we're testing out for mechanism, most of the clinical trials that we're doing right now are we're running them because enough patients said to us, I was at a plateau, and then this was the thing that moved the needle for me. So some of the therapies like low-dose rapamycin,
Yeah.
we're about to start a combination antiviral clinical trial of a antiviral combination called the Putrino protocol, which is Valtrex, Celebrex, and Paxlovid.
Yeah.
The reason we're running that trial is because so many patients came to us and said, I was stuck, and this was the thing that moved the needle. Now, that's not validating the drug combo as a target, but that sure is giving us enough information that we say, hey, let's do a proper RCT on this so that we can figure this out once and for all. And so I do think that there are therapies, but it does require, a bit of a thinking about fresh approaches sometimes. One thing that we sometimes do within the core is our Cohen Center is some of our providers will, just switch patients just to get a fresh set of eyes. Or,
Oh.
Again, we'll every Friday at 4 p.m. we'll have like just a little rounds where if someone's stuck and they feel like they've tried everything, they can present to the group and say, what am I missing? What's next? Does anyone have any ideas? So I think having that sort of like fresh eyes on it and maybe someone who's seen a new paper or something like that, that's helpful.
Yeah, so yeah, we have to often see that same thing where I think for the silk endeavor has helped us kind of provide us with some fresh ideas. We've gone through multiple interventions, also giving Valtrex and Celebrex and a variety of immunomodulators, and we haven't, oftentimes we'll see some improvements and then it'll plateau, and so uh, yeah, it's
Yeah.
yeah.
No, I mean it's tough, and you got to keep pushing, and right now I don't know that we have, you know, I'm especially in people who have been sick for a while. I personally, I'm always like very cynical and suspicious when I hear about complete remission. I'm like, okay, well let's think about that because I agree it is tough, and I think the best we can hope for is little step function improvements with each new approach that makes physiological sense. And maybe we get people back to, you know, better functional levels. But
Do you think
I
Do you think
oh, go
that
ahead.
there's a unifying mechanism? Because there's so many, autoantibodies as well as immune dysfunction or clearance and inflammation.
Yeah. I
What do you
I
think?
don't think I don't think that there's a unifying. I think you need to break it down, and you need to understand, is it one driver or another? Is it lack of clearance of antigen? Um, is it just someone got hit with terrible post-viral, and I'm using that term intentionally, post-viral POTS or dysautonomia, and as soon as you treat the POTS or dysautonomia, they feel fine. Uh, Figuring that out, I think, becomes very important. I saw in the chat, issues from vaccination. Um, I think the answer is yes. I think that we have some people who are vulnerable to an inability to clear spike. Akiko and I pre-printed a paper. No one will publish it. No one will publish it, despite the fact that it uses identical methodology to our paper that was published in Nature. And we have a comparable sample size. Um, what we showed was that in people who were vaccine injured, and so the cohort of vaccine injured patients was anybody who developed symptoms after SARS-CoV-2 vaccination with an mRNA vaccine, who had prior to the mRNA vaccine tested negative on a rapid antigen test for COVID, right? So those are our inclusion criteria. So one can never be 100% sure, but we were pretty sure that this was chronic symptoms brought about by vaccination. In that paper, we showed using Samoa testing that their spike protein in their plasma was on average 6 times higher than spike protein found in plasma of people with long COVID. So, you know, so indicating that persistent antigen is potentially a problem in a subset of people. And, what we say in the paper is very clear. We're like, look, this is a small percentage of people who are having this reaction, but it's real, and that's why with our upcoming monoclonal antibody trial, we're actually going to be recruiting folks with long COVID or vaccine injury because these folks deserve some answers as well. Um, and I haven't seen a clinical trial for them yet. So, we're hoping that this will be the first one.
Yeah, Renata was mentioning, is viral exposure consistent, thereby patients exhausting the immune system from ongoing exposures from antigen versus persistent of one-time exposure that doesn't clear?
Um, I think that again, um, I think that certain people have uh, either physiology that makes their bodies more susceptible to a persistent antigen or persistent pathogen that is taking root in tissue. And then also some people just get hit very hard by the virus, and so they do get an outsized, viral exposure. Um, what we do know is because there's a number of variables at play here, and I think that these variables are genetic. I think that, something that we've seen over and over again, to just pull one example, is um, you know, people with certain variations of the MTHFR gene are more susceptible to post-acute infection syndromes or infection-associated chronic conditions and illnesses. So you've got people who have genetic susceptibility. You've got people who just get a much bigger viral load for whatever reason. You've got people who, for whatever reason, their physiology is reacting to antigen that in other people their tissue just tolerates, being around. So I don't think we have a consistent reason why one person is developing these symptoms versus another. I think again, unfortunately, just like no unifying theory, also no unifying perfect uh, long COVID patient or long COVID patient predictor.
And so Yvonne was mentioning, are there any plans to study MMT in ME patients? And why doesn't anyone besides use ME in disease control groups?
Yeah, we actually have a number of clinical trials where we recruit pre-2020 ME alongside long COVID. And we also use chronic Lyme as controls as well. I think the short answer to why is this not so common is just funding. I think that a lot of groups that fund this sort of work are very laser focused on one condition as opposed to all. I think that we're big fans of groups like the Cohen Foundation and Polybio because they really are trying to create unified platforms. Not only are they funding research across disease states, but they're also bringing together researchers to make sure that we're not wasting efforts at cross purposes. We're actually doing research in a collaborative way that conserves resources. But I do think that it's really important, and this is a messaging that has been consistent at the Cohen Center for a long time. We have always said that, we need to get all of these conditions under one roof so that we can study the similarities and the differences um, consistently and together, rather than saying we're just the long COVID clinic or we're just an ME clinic or we're just the Lyme clinic. We learn so much more when everyone is side by side.
Thank you. Yeah, I noticed on your center you have a Lyme also on besides the viruses and parasite
Yeah,
bacterial.
yeah.
Okay.
We actually have a really interesting study coming out where we're showing that uh, parasites like Babesia, which are carried by ticks, can be reactivated by COVID. And we think the
Oh,
reason for this is because what we've seen in animal models is that Babesia is a parasite that goes dormant in the endothelium. And so if SARS-CoV-2 infection is causing endothelial agitation, endothelial inflammation, it stands to reason that you may be reactivating a pathogen because of that. And so we are running the first trial in history, actually, of chronic babesiosis infection, which was a really interesting process of talking to the FDA and talking to the CDC and having acknowledgement that chronic babesiosis can exist. Um, and then getting the opportunity to actually run a clinical trial using tafenoquine actually is the drug that we're using in this clinical trial to treat the chronic babesiosis. And Lisa, just pop the link to the manual in the chat.
Okay,
And
perfect. Oh, go ahead.
okay,
Sorry. That was it. All right, so I'll just give it a second. Does anybody else have any questions for Dr. Putrino? No, it looks like we're good here. Well, thank you so much, Dr. Putrino, for joining us tonight for you. We appreciate you being here. And to everybody else, if you're interested, our next session is on Tuesday, August 25th. And that night we will be discussing mast cell activation syndrome. So hope to see you there and to have a great rest of your evening. Bye.